Dear colleagues, ladies and gentlemen, I think it's time to start this very interesting session. We will have two great speakers this morning. The first one is Reid Henderson, that you all know, and the second one will be Patrick Seris, that you know as well, of course. And this session will be dedicated to the history of development of Tavi. It's a long time ago. And Patrick Seris will offer us a vision of the future. So I think it will be quite exciting, and I have the pleasure of chairing this session with Suzanne de WAHA from Leipzig, and I am Dr. CRIBIER from Rouen, France. So I think it's time to give the microphone to Reid Henderson, a great name in cardiology. The title of his presentation is Tavi, from the theoretical concept to the clinical ground, steps into the success, major difficulties, and times of frustration. Reid?
Thank you so much, Mr. Chairman, ladies and gentlemen. I'm going to tell about the conception of Tavi many years ago, and this is my conflict of interest. I'll take you back 23 years from now, back in '89. I was attending a vascular meeting, and I was sitting like you and listening to some speakers talking about coronary stent implantation in dogs. I never heard about it, and I became so fascinated. And then suddenly I got the idea, Henning, why don't you do these devices 10 times as big? So instead of 3 millimeter, make them 30 millimeter and put a foldable valve inside. Then it should be possible to implant artificial heart valves without doing surgery. And I decided that I wanted to be the first in the world who implanted such valves without doing surgery. I put 4 requests in front of me on the flight back to Denmark. It should be a closed chest procedure, beating heart procedure, closed heart procedure, and it should be performed without cardiopulmonary bypass. Now, the first challenge was to build a stent. I tested different metal wires, and this was what I ended up with. I stole these devices from our cardiac surgery colleagues, and this is what they use when they close the sternum after a thoracotomy. I developed this extremely complicated machine to bend the wires more regular. Indeed, it's called Sky because my hospital is called CRIBIER Hospital. I made 2 of them. I bent them together with what I call cardiology nuts. And then I needed a heart valve. I went to the butcher and bought some pig hearts. And this is the ascending aorta from such a pig heart with a 3-leaflet aortic valve. I cleaned it manually with scalpels and scissors and mounted it inside the stent with even more cardiology nuts. This is seen from above in the closed fashion, and then it can open, it can close, it can open, and it can close. It seems to work. I have learned in Phoenix that I should crimp these devices with my fingers on a balloon. And this is the crimped valve. Indeed, it's very, very bulky. But it's, this was what I could achieve. I had to make everything with my own hands. I didn't have engineering or money or technicians to help me. The diameter here is around 10 to 11 millimeter. I made a few in vitro testing. This is an X-ray of the crimped valve on a balloon inside a specimen of aortic vessel from a pig. Balloon inflation, implanted, and as you can see, the stent overstretched the vessel a little bit. When I pour contrast towards the valve, it seemed to be fairly competent. You can actually see the 3 sinuses down here from the valve. Now, the next challenge was to build an introducer system. And I can tell you this is the introducer system. It's actually a 41 French introducer sheet, nearly 14 millimeters in diameter. And you can see the balloon out here at the tip of the device. Here's the crimped valve on the balloon, inside, expelled, balloon inflation, and a close-up view with all the beautiful cardiology nuts. Now, next step was to find an animal model. And indeed, you cannot use a mouse or a rat or a rabbit for such a device. You have to find something which is bigger. And this is a little bit bigger, and I just want to make sure that all of you knows what is going on here. It's not me lying down there, okay? Just to make sure. I'll show you a film from '89, from May 89. The quality is very bad indeed, because it has been stored on videotape for many, many years. To the left of the screen is the head of the animal. Here you see the guide wire. Here's the stent coming up. And the very first here is going to implant it in the so-called hoof-knuckle position. This is where our surgical colleagues started to implant valve many, many years ago. They didn't do it in the subcoronary position. They did it here in the descending aorta. So now it's implanted. We put a pigtail catheter into the left ventricle and do an angio. And you'll see the stent is overstretching the descending aorta. Next implantation. You think that valve-in-valve is a new thing. No. Valve-in-valve was done 23 years ago. This valve is going to be implanted in the subcoronary position. And when you do catheterization like this, it's very, very important to keep track on your guide wire. Otherwise, you have a problem. Now, when the valve is reached the correct position, there's also another thing which is extremely important. Remember to remove your pigtail catheter. Otherwise, you'll have a major problem. And then, simple procedure, balloon inflation. This is the first valve, now the second valve. And this is 23 years ago. Now we'll do a retrograde catheterization. You can hardly see it, but this is a pigtail catheter going trans valve and into the left ventricle. We do an angiogram, and you can see it's implanted in the subcoronary position. And we'll do an aortogram. You'll see valvular leak, indeed. And we'll do a selective angio just to demonstrate that this is really in the subcoronary position. This is the post-mortem PICC heart, the ascending aorta, guide wire in the right coronary artery, in the left main and LAD, and this is the left circumflex. This is a close-up view of the implanted valve with the guide wire, and the native valve of the PICC is compressed between the metal and the vessel wall. This is a look into the left ventricular outflow tract. The valve is implanted, and indeed this is the mitral valve. So, the 1st of May, '89 was the very first implantation of such a Tavi procedure. And I was happy, because indeed this must be a beautiful invention. Everybody would be happy about it. Think about it, it's just for the last 5 years this has exploded. So it took me 2.5 months from I had the idea until proof of concept, until I did the first implantation. The very first presentation was at a meeting in the Danish Cardiology Society, their 30-year anniversary symposium, and it was in May '90, 1 year after I did my invention. It was accepted as a lecture in a Young Investigators Award competition on the 19th of May, and there was a list of distinguished moderators. One of them is sitting just down there, Patrick Royce, he's the next speaker. So you have known this technology now for 23 years. Indeed, you want to publish. So we made a series of implants and sent our manuscript to Jack. At that time, Jack had an impact factor of 5.9. We are now in July '90, and the result was it has too low priority for publication. You should never, ever give up. You should always fight for your idea. So we made extra implantations and sent the next, the next manuscript to circulation, even higher impact factor. Now we got this answer back in February 91. His priority remains too low for publication in circulation. Okay, you should never, ever give up. European cardiology meeting in Barcelona. This is a young, happy inventor. He's waiting for all the crowd, all the guys coming to study his great poster and his invention, but nobody came. Nobody came. Maybe because this was poster number 2,380 in the faraway corner. A few months later, same story, American Heart Meeting, New Orleans, and now I was getting annoyed. Nobody came. It seems to be a stupid idea. Nobody was interested. We could hardly publish. Circulation, no. JACC, no. We ended up, happily, sending our manuscript to European Heart Journal, and now we are in October 91, and certainly it was accepted. At that time, European Heart Journal was a very low-ranked journal. Internationally, it didn't mean anything. I have heard rumors, it's just rumors, I've heard rumors that one of the reviewers of my manuscript is also sitting down there. He's also the next speaker, but I have never been correctly informed, but I've heard rumors. What about the industry? Indeed, I knew that I could do this with my own hands, but I needed engineering, I needed a company, I needed investments, if I should bring this further. And I could tell you a long, long story about how I attacked the industry. I won't do it today, but I'll tell you two small stories after I've had a cup of water. When I presented for the very first time in Denmark, I was approached by this Mr. Green. Mr. Green, he was the chief of European regulation for the company called Baxter. And this was in June 90. Now, the reason why this is a little bit funny is that at that time, Baxter owned Edwards Life Science. Edwards Life Science is one of the two major players on the market today. So this company actually had everything served on a silver plate. In 1990, there was proof of concept, there was demonstration that it worked, there were animal results, there was a manuscript which I actually sent to them, and there was a patent application filed. Everything was served. I didn't hear anything from Baxter. There was another small company located in northern US, they were called Medtronic, because when I didn't hear anything from Baxter, I waited a few months, and now we are in July 90. It was quite the same. I cannot meet with this Dr. Anderson. So I tried many more companies, but it was just impossible to have a company interested in this. So we really felt that we were down to the ground. We were beaten. There was nothing to do. And even when we were down there, it was a catastrophe. It didn't work. It didn't work. We lost the game, no doubt about it. We lost the game. So this was really the ugly duck. From 89 and for the next 13 years, it didn't work. Until Professor CRIBIER in April 2002 made the very first implantation. It was really the major breakthrough for this technology. In the late 90s, some groups around, in Europe especially, started to reproduce my animal experiments. And I also know that Professor CRIBIER had worked on this idea for many years. The major breakthrough came with the first in man, the 16th of April 2002. And indeed, we should all recognize that this man was the pioneer who really made the major breakthrough. We should also thank the patient, because he knew that this was first time ever an experimental treatment, and he said yes to it. So in my own hospital, we also have very important patients. For example, this guy, he is 66 years old. The reason why he's an important guy is that he's actually my father. My father had a Tavi procedure in 2011. I didn't implant it myself. But for me, it's very special because what I invented back in '89 as the ugly duck was transformed by Professor CRIBIER into a beautiful swan in 2002, and now it comes back to my own family. So it's like the circle has closed for me. And this man, he's now 88 and still going strong. There should be some sound on this, please.
Havde gang i skulle komme mig til gode på nogen måde.
He's our old Viking of the family.
Så store, så det var nødvendigt. Det var nok 6 år siden, at jeg begyndte at undre mig over, at jeg dyrkede lidt motionsløb. Og der begyndte jeg at tabe tid, når jeg løb. Og jeg blev mere og mere forpustet. Det var der, det startede med, at der var et eller andet, som jeg ikke hæftede mig så meget ved. Det var der bare.
Ja, min mand, han havde det dårligt, før han blev opereret. Han kunne ikke rigtig holde til noget, og han kunne ikke få luft. Det var det selv at tage tøj på om morgenen, det kunne være en stor belastning. Så kunne han pludselig sige, nej, nu kan jeg sgu ikke mere, for at sige det.
Ja, det endte jo med, at jeg i gang med ligesom tabte modet. Og hvad gør man så? Man sætter sig et eller andet sted, eller ligger sig, eller beder alle de andre om at holde mod, fordi man har det ikke godt.
Da jeg blev klar over, at min far havde aortastenose, for snævert hjerteklap, så var mit mål og mit håb, at de mennesker, der havde med ham at gøre og skulle vælge behandlingen, valgte den bedste behandling til ham.
Hvad var det så, vi skulle have her?
Da mine kollegaer kom og sagde til min far, at de anbefalede, at han skulle have en Tavi-procedure, en katheterindsættelse af hjerteklappen, der var han godt klar over, at det var min opfindelse, han så skulle behandles med. Ja, det var han klar over.
Jeg talte med Henning om det, men ikke ret meget. Fordi jeg synes ikke, det var noget at udbrede sig så meget om.
For som lægen sagde den dag, han skulle tage stilling til, om han ville til Skyby, så sagde han, du er jo frisk i hovedet, og du kan få mange gode år, derfor vil jeg indstille dig til at få en ny hjerteklap på Skyby sygehus. Og han sagde ja med det samme.
Da han var blevet behandlet, og han havde det rigtig godt, kom jeg over og snakkede med ham efter nogle få timer. Og der lå han der i sengen og smilede og drak sin kaffe.
Børnene synes jo, det er vældig godt, vores far han i den alder kan få det bedre. Der var stor forskel på min mand. Nu kunne han pludselig sætte en hel ting i sving. Nu skulle han det, og nu skulle han det, og han var næsten ikke til at styre. Og han blev ikke sådan træt. Fordi nu kunne han jo få luft. Det er jo lykke.
Thank you for your attention.
Thank you so much, Rod, for this unbelievable story of the development of such a thing. And you know that I know how difficult it is, to bring an idea to the real world, that you have to face all the criticism and the skepticism of the negative opinion of all the experts in the world. So congratulations for what you have been doing, Rod. Thank you very much for coming here.
Thank you so much.
Thank you. Well, now we had a look on the past, and we will have a look on the future with Patrick Series. Can you introduce his talk?
Well, now some words from a visionary outlook into the future from Dr. Series. Thank you.
Yeah, it's difficult to follow such a story, and I'm happy that I have made two very small contributions. Indeed, I signed some document so that your own group will give some money for your project, and then in the editorial board of the European Heart Journal, I said, we cannot let pass that. That's a good paper. There was also an editorial called Back to the Future that I wrote after this paper. Okay, this is going to be somewhat drier, less emotional, certainly. It is what will be the Tavi's future, which development can we still expect in the forthcoming years. We have to recognize that in the first place, in the 60s, the surgeon introduced the homograft, the mechanical heart valve, the porcine valve, and the pericardial tissue in less than 1 decade. And then it is so dry on a slide, it is a small black, but here is Henning with the film and the 30 minutes of story about his first experience. They were also the first PVT animal implantation by Alain CRIBIER, and later on the first core valve animal implantation by Jean-Claude Laborde, and then, as said by Annie, came really the critical moment, the use of the first PVT human valve integrate approach by Alain CRIBIER. And I will never forget the procedure that we did together in Rotterdam. I realized how complex it was and how skilled you have to be to do this integrate approach. Then we had the retrograde approach of the core valve Tavi. We had the transapical with Sam Lichtenstein and John Webb, the first Edward transapical, and then we get the two big trials, the partner Cohort B and Cohort A, and today we are busy with the Tavi and the partner 2. So the future. The future, I think it's clear that Alain started by the most complicated patient, the opposite of Andreas Grunzig. He started by the inoperable patient. Then we went to the very high risk, more than 15% operative risk, to the high risk, 10 to 15. And today we are running trial in the intermediate risk, which is between an STS-4 and the STS-10. And I can tell you that the discussion that I had with the FDA were extremely difficult, and the discussion that Marty Léon had with the FDA were also extremely difficult, and we both end up with trial having an STS between 4 and 10. And of course, as physicians, sometimes we have to recognize that surgery and the transcatheter treatment will be futile and the patient will not benefit. We are not gods, there are limits. It's clear that today, strictly speaking, it should be applied in patients who cannot undergo surgery or in patients with high risk. But as I said, we have the Medtronic core valve pivotal US, IDE, non-inferiority versus surgery in a population who has an STS of 15, thus an operative mortality risk of 15%. And then Marty Léon with the partner as the intermediate risk non-inferiority study versus surgery, STS greater than or equal to 4 with a syntax score of less than 33. And we have a trial which is US and Europe, non-inferiority, 1,800 patients, an STS grade of equal to 4, and a syntax score less than 23. That's the present and the future. Now, all these trials are based on non-inferiority because the key question is the durability of this treatment. And we know from the surgeon that the risk accelerates structural valve degeneration of bioprosthesis with younger age at implantation. Basically, if you implant this valve at the age of 20, you have a 90% chance to have a destruction of the valve before the lifetime. The second point is that we know that around 55, 60 years old, the even free life expectancy of the bioprosthesis is superior to the mechanical valve. That's the reason why we are using them. And then what is clear that with time, and there have been plenty of experiment, that the porcine in blue is inferior to the bovine pericardial bioprosthesis in terms of durability. Now, the future of Tavi, durability, we have today limited data with regard to the durability of the available valve. We have officially a report with a mid-long-term follow-up of 3 years. Of course, Alain has patients which are close to 7 or even 8 years. But as a series, having a mid-term, long-term follow-up, it's one series basically of a few of them. In this series, we see that the echocardiographic examination showed low gradient and moderate aortic regurgitation in 6%. The CT scan confirmed the absence of stent fractures, a small reduction in the AV area, and structurally normal valve. And in postmortem examination at 3 years, the valve is structurally and functionally normal. But we obviously need more data on the durability. Why? Because the surgeon himself has observed that you could have terrible degeneration of these bioprosthetic valve. You can have pannus, you can have thrombus, you can have calcification, you can have tear, you can have endocarditis. You could say it's not frequent event, but as I say, is a function of the age of the implantation, and we may face that problem in the future. And of course, as mentioned for the mitral valve, some of the future of Tavi is that we can do valve in valve. We can help the surgical valve when the surgical valve starts to fail. And the current data are restricted in small case series. Although it is feasible, the long term is totally unknown and unclear. One series has been published by Niccolo Piazza. It's 20 patients. It was a high success rate, but nevertheless there was a mortality of 15%, 1 MI due to left main obstruction, as you could see here, 1 stone heart, and 1 patient dying to severe paravalvular leak and cardiogenic shock. So what is the future? The future in the first stage is that Edwards, like CoreValve, like many other, are starting to use anti-mineralization treatment of their valve, alpha-aminoleic acid, and that should prolong the life, the endurance of the device, and the lifetime of the device. The future is probably, but that's a part of science fiction, cell seeding. This is a paper published in Circulation in 2005. What these people did, they used an autologous prosthesis consisting of a bioresorbable frame which was covered by bone marrow-derived mesenchymal cells. Of course, you have to do that surgically. It was tested in the animal. As I said, it requires surgical implantation. The follow-up was short, but the results were promising. And more recently, in the European Heart Journal last year, there was this publication showing a valve with autologous tissue engineering heart valve. It was developed, seeded again with bone marrow mesenchymal cells. The valve was implanted transapically in 6 baboons. They did relatively well with some aortic regurgitation, and explantation at 4 months demonstrate endothelialization of the prosthesis, but some shrink leaflet. Can we go further? Yes, I think we can go further. This is an example of nano synthesis. This is not new. It's a kind of tank. You have to do extreme vacuum to eliminate all the contaminant. You have this electrical field. You can excite ion and bombard the central mantle with the ion one by one, nickel and titanium, and you can really have a perfectly defined ratio of deposition of these ion by changing the internal chamber characteristic, and you can modify the thickness of these ion, and there is the argon which is helping in transferring one by one these ion of titanium and nickel. Now, is that science fiction? Not really. This is myself stretching as much as I can these mechanical leaflet made of metal, and the endothelium love them. They love to grow very quickly on these leaflet. And as a matter of fact, there are animal who has been implanted, and the great news is that it can be introduced for the aorta by a 10 French catheter. I was thinking about your 41, yeah, and for the venous system by 4.8 in the venous system, even the pulmonary artery. I can show you many films, but this is just an aortic view in the animal, sometimes after the implantation, and this is the ventricular view. That's enough for the future. Now, what about the patient assessment? I think that this cartoon tells me a lot of things. We start with a dialogue between cardiac surgeon and interventional cardiologist and non-interventional cardiologist, but today we see we are helped by geriatrician, nephrologist, neurologist, pneumologist, and so on. So it is really a teamwork. And the big issue today, and we try to work on that, is that we don't have a Tavi risk score. So we're still using the STS and the Euro score. And as you could see, the prognostic value is very poor of these typically surgical score. The traditional surgical score does not take into account known risks like porcelain aorta, frailty, and liver failure. So we are working, trying to develop a specific Tavi risk score so that we will be able to predict the future of our patient more precisely than this rough area under the curve. It's clear that today we use multi-slide CT scan intensively in the pre-screening of our patient. All this information is circulating electronically. We look at the presence of peripheral vascular disease, tortuosity of the iliofemoral, assessing the AV annulus, assessing the AV complexity, and looking at the coronary anatomy. And it's clear that a valid and accurate risk stratification would facilitate the decision-making process and permit more objective selection of the appropriate patient. Another change is the access route. You have heard the retrograde approach of Alain CRIBIER, then the anterograde approach of Alain CRIBIER, which become a transapical approach, and at a certain point became the subclavian. By the way, it's very interesting. I didn't realize that Peter de Jager and myself, we did the first subclavian, but I didn't find that so important, so we never reported. And today, what is really coming frequently as an access is the direct aortic. It's a small cut parasternal, and the interventional cardiologist of the intervention put the valve through the aorta. In terms of imaging, it's clear that techniques like 3D echo are playing a great role, and I was impressed at the last London valve to see physicians relying completely on a 3D echo to implant the valve. And you see here the structure, you see the inflation of the balloon, and you see the metallic structures of the device which is let in place. Let's see again the inflation of balloon for a few seconds. Not only you have the 3D echo, but you have this 3D reconstruction from conventional angiography or rotational angiography. And that facilitates also considerably our work in selecting the angulation to visualize the aortic root and annulus the best we can, either using the conventional or the rotational angiography. And you can do the things even more complicated using the Dyna-CT, for instance, developed by Siemens without advertisement. Utilize the data acquired by rotational angiography to reconstruct the aorta, like we see here, and then the obtained model can be superimposed on the aorta fluoroscopy and facilitate the optimal device implantation. And the next slides show basically the same. That's the so-called heart navigator. What you could do is a 3D reconstruction of the aorta, correct sizing of the prosthesis. You can overlay the CT on the angiography. You can select the optimal view, and you can create an overlaying image showing the aortic view in relationship to the aorta. What about the valve? This is something that we published recently in Neurointervention with Nicolas van Mighem, Nicolo Piazza, Yoshio Numa, Wasim Farouk, and Chris Burantas. I'm not going to review all this valve, but I'm going to tell you what is new by a few features. If you take the engager of Medtronic, you have, of course, I told you bovine is better than porcine, so it is bovine. You have these arms who have to be positioned over the leaflet. There is a lot of attention for the skirt to avoid the paravalvular leak, and you have these dedicated commissural posts for a valve positioning. This is a valve which has an aortic, that's direct flow, which has an aortic ring inflatable, a ventricular ring inflatable. It is bovine, of course, and it is retrievable and repositionable, and you see the gadgetry to achieve that. This is another example of something which is retrievable and repositionable. It is, of course, in nitinol. You see again this anchoring mechanism specific to the Jenna clip, and this is CE mark. Another variation insisting on the stabilization arm and on the skirt at the bottom. This is the one of Boston Scientific, the Lotus valve, retrievable and repositionable. That's a must these days. You have this adaptative seal here to minimize the paravalvular leak. You have the nitinol frame designed for the retrieval and the repositioning, and of course we are the bovine. What seems to be a copycat of the core valve, that's the portico of St. Jude. You have these large stent cell to have easy access to the coronary artery. That's a little bit like the core valve. But what is interesting is that the tissue cuff is designed to minimize the paravalvular leak. What they have done is that the leaflet has been inserted very low at the extremity of the cuff so that you can limit the protrusion of the device into the left ventricular outflow tract and try to eliminate the conduction defect that we have seen sometimes with the core valve. And then Edwards is coming with brand new technology. The Centera, you have a motorized, I don't have the time to show you the video, but we have a motorized delivery system which provides great stability and allow a single operator to do the valve deployment. You don't need two persons, you do everything by yourself. We are suddenly in the 14.5 French. Remember the 41 of Henning. It's bovine. You have the valve is anchored in the annulus. It's repositionable. And then you have the sapien, 14 French, bovine. Also here at the bottom, if you look carefully, these customized sealing cuff which reduce the paravalvular leak and the anchor to embrace the annulus. So if I can summarize, it's still the future, but it's already the present. We are step by step with all these approach that I have described, limiting the paravalvular leak, limiting the suboptimal deployment, limiting the conduction disturbance, limiting the risk of coronary ostium obstruction, and it's certainly easy to use once you have a motorized delivery system and you are alone as operator. The stroke conundrum is certainly the future. I mean, still today we don't know if there is in the stroke appearing the first month, if it is something related to the platelet, to the anticoagulation, the anti-10A, if we can achieve major result with embolic protection, and how much we have to control these episodes of atrial fibrillation. That will keep us busy for 5-10 years to fix that, and I hope that the pharma company will help us. Certainly the surgeon has a major interest in that. If we look at the embolic protection, the FDA was nervous about the partner trial reporting 6.7% of a stroke, and in the high-risk patient 5.5. Now, this is one of the first device, the claret, which is CE mark. You insert through the radial artery. It has, as you could see, two filters which protect the brachiocephalic and the left common artery. The device was tested in a small feasibility study in 40 patients, published in Eurointervention, and the debris was detected, mined in 54% of the filter. Now you have the chef, which is an heparinized filter, which is placed in the aortic arch and operate as a debris deflector. It goes to the descending aorta. It can stay in position for months. The device was tested in a small study in 15 patients. There was a 50% reduction in the cerebral lesion detected by MRI comparing to the control group. And then finally, you have the umbrella embolic deflectors. It protects the brachiocephalic and the left carotid. It is delivered through the radial artery. It has been tested in 18 patients, and also with MRI we see less defect. There is also progress in the sheet. That's a great idea to have an expandable sheet. So the E-sheet allowed for transient sheet expansion during the valve delivery. It has a diameter of 16 French and expand to 18 French, allowing the smooth delivery of the valve and then return to its initial status, as you could see here. And we have even the Solopat, which is a balloon expandable sheet having a diameter of 14, and you can expand to 18, and I've seen the second generation sheet which allow the deflation of the sheet post-valve deployment. This is for the sheet. Now the vessel closure, then the landscape is huge. This is a slide that we have done with Marty Leon some times ago. As you could see, there are emerging suture. There is also a patch plug. You see the name of all the company. I'm not going to describe all these devices. The strategic player are Medtronic, Abbott, St. Jude, and Cook. That's for the femoral. But what about the apex? And there also, for the apex, there is a family of company who has designed and test used for transcutaneous ventricular access and closure. So if you want to be in, you are talking about TVAC now. okay, how many TVAC we have. And you see it looks, I'm not going to describe this device, but some of them are nice corkscrew I think you could use to open a bottle of wine with this device when they are being used for the patient. So conclusion, it's time to conclude this kind of overview with vision on the future. I think that the value of Tavi is largely demonstrated in symptomatic aortic stenosis. I think strictly today we should restrict to symptomatic, inoperable, and high-risk patient. I don't know if you have read the editorial in the British Medical Journal. It was quite aggressive. As we become more familiar with this treatment and the new technology in valve design and the enabling device, Tavi, probably there will be a continuous expansion of the Tavi application. This can be achieved only if we demonstrate the safety and the superiority of at least the non-inferiority to the surgical approach even in the lower risk population. We are already in 2 major trials with the FDA, Edwards and Medtronic. At the value of 4, the next will be from 0 to 4. I don't know who is going to do that, and we have to see first the result. And the final conclusion is that certainly in the future, we have to facilitate the identification of the appropriate patient for treatment. We have to improve the design of the available device and Tavi enabling system, and I've shown some of them to reduce the risk of complication, the vascular complication. We keep improving the imaging modality, which are of paramount importance when you work in the heart, and at some point we will have to work on the cost effectiveness. Now, the advances in this field are likely to enhance the application of Tavi and probably allow its implementation in the treatment of other valvular pathology. And in the aorta, the other valvular pathology is the aortic insufficiency. So I will finish this talk by a short video, which is quite remarkable. This is a very young Indian patient, 32 years old, and as you could see, he had a major aortic insufficiency, grade 4. Look at the expansion of the ascending aorta. It is fascinating for a young patient. Now, this is a core valve. As a matter of fact, it's the 3rd implantation worldwide of the core valve, which was in aortic insufficiency of this young patient who had, by the way, non-curable disease. And then procedure is finished, is almost in real time. And I'll show you the result, which is impeccable. Access to the coronary artery is extremely easy. And I'll show you again the initial status, which was in the aortic insufficiency grade 4. So there is a future there too. Thank you.
Thank you very much, Patrick, for this fantastic overview of the state of the art and the future. I think it's now time to close the symposium. Thank you for the attendance. Thank you very much.